and I assume that we're all here for a practical review for Bio 110 specifically, yes? Yes. And so what this is going to be, it's scheduled for 2 to 3. It's likely going to be more like 3:15, 3:20. I will try to move quickly, so if you have a question, you got to raise your hand and ask it quick so we can keep this moving. There's a lot of information to get through, and that becomes front and center to your challenge of the week here as we get ready for the practical, all right? So just as an inspirational thing, it's not about how smart you are, it's about how much effort you're putting in. So please make sure you're blocking out enough time to get yourself the exposure with this material as many times as possible in order for you to have maximal success, right? So we started out just after the practical, and this practical here for the final will only be for the second half of the semester. It is not cumulative. So it's basically from axial skeleton forward, right? And so just to get us started, we've got the skeleton here. The axial skeleton is sitting there basically around the axis that you spin around on, right? Which is skull, spinal cord, ribs, or spine, I should say, ribs, is the axial skeleton versus the appendicular skeleton, which is doing your appendages, right? Including the large surface area bones that we're going to need to attach to big, powerful muscles that are going to run your limbs here as well. Which is why bones like the scapula are officially part of the appendicular skeleton, not the axial skeleton. I'll be touching the screen and doing that all day long. All right, so from there then, our main work here in the axial skeleton is the skull. So we've got these colored up skulls we had in lab for you. Understand that unless you've got the most naive or the nicest lab instructor, this is not the skull you'll be tested on. Instead, the skull you're tested on will look closer to that. So we use this just to make it easy for me to point out things to you, especially in the back of the room from where I'm on up here. But you learn them like this, but then you must transfer them to this in order to actually get the points, because this is the one you're going to be tested with, right? For today, I'm using the colors. That way I can get the whole room involved, right? So your frontal bone is the first one, and that's right up here in your frontal area, just above the frontal lobe of your brain. This is your forehead, right? And so that's this purple guy right there. And this is straight up definitions, yes? And locations. So there's your frontal bone. Now just inside the frontal bone, you've got this space. And one of the models I forgot to ask for was the sinus model, but we've got a frontal sinus right there in that frontal space. And let's see how far away I can get from the screen. So here's your frontal sinus. There is how that works here. I'm also going to try to use my pointer, which doesn't work on the screen. In there, that's the purple. And in our model of the sinuses, you should have this one under your belt as well. It's the yellow right here. Frontal sinus for your frontal bone. Questions so far? All right, so we keep the terminology easy to begin with. Then we get the temporal bone, and that's this bone up here, basically over your ear. Your temporal bone holds your acoustic meatus, which is the hole that your ear is going to actually make, right? And that is also going to be holding on to a zygomatic arch right there, which will become the back part of your cheekbone. So it's the side of your skull down to about your ears, which is your temporal bone. And this is too far, so I'm going to stick myself right up here in the corner. With the temporal bone, if we open up the skull, we can see that the bone here is very, very thick on the inside. That's called the stony region, or the petrous region. And so, like petrified, right? And so in here, this is where all of your balance and your hearing structures are, your cochlea, your semicircular canals that you'll learn about in 111 next semester. And so it's just a bunch of tunnels kind of carved out into this thick bone, so all of the structures of your balance and your hearing are also embedded in the temporal bone right here, the petrous region. As far as a sinus that can be associated with this is these purple guys next to your ears called the mastoid sinus. Then we've got your parietal bone. Now your temporal bone is down here by the ears. Your parietal bone is the top of the sides of your head on either side, right? And there's not a whole lot to be said about these guys, with the exception of this line that you see, the suture that holds onto your two parietal bones, and how it interfaces with this brown bone, which is called your occipital bone, for over your occipital lobe. That's where you see in your brain. See how this kind of looks like a Mercedes symbol? That is the Greek letter lambda. And so as a consequence, this particular suture is called the lambdoid suture. And it's one of the sutures that you're supposed to know for the exoskeleton lab. Questions there? All right, so parietal bone. Right over the parietal lobe of your brain. Then we've got the occipital bone. That's this guy down here, the brown we just talked about. This is over the occipital lobe of your brain. I hope you know at this point, but if you don't, you will by the middle of next semester, that your eyeballs take in the light, but you don't see anything until it hits it back here, which is why getting hit in the head with the back of the head with a baseball bat or a pitch, it can lead to blindness. See The Sandlot if you've ever seen that movie, right? It's also why we've got the batter's helmet here. It's simply so it's not to protect your ear. Yeah, it hurts, but oh well. It's to protect the back of your head here, because if you get hit with a fastball in the back of the head, next step, blindness is a risk. So that's why they've got that big protective thing. And that's simply because the occipital lobe, occus meaning eye, just underneath the occipital bone here. With the occipital bone, we've got the hole that your brain is going to meet your spinal cord with. That's called the really big hole, and that's the foramen magnum. And if you look at what those terms actually mean, it pretty much means really big hole. And your spinal cord comes out that foramen magnum right here. We've also got these occipital condyles here, and this is what the atlas bone, that C1 vertebrae, is going to hold on to your head with. And the action of that C1 vertebrae on those occipital condyles here is going to give you the yes motion. So your first cervical vertebrae allows you to nod yes. And then if you remember, we'll get into this, but your second cervical vertebrae, the axis, is what allows you to go no. And it's simply because that smooth part there provides a nice, shiny surface with low friction. Questions? All right. Then we start to get into the more of the internal bones. Your sphenoid bone has these wings, and it's here, this green we see. And you're not going to really see this very well unless you open up the skull. But what this is going to do is set up the base for things like your pituitary gland of your brain. And so one of the bone markings here in the sphenoid bone, this winged bone, is this piece right here called the Turk's saddle. Because it kind of looks like a saddle if you've ever ridden horses. And the person that's riding it is your pituitary gland. And so this is how we set up a connection between your nervous control and your hormonal control. And we actually give that hanging pituitary you learned about in the brain lab, or you will if you haven't gotten there yet. It sits right there in the sella turcica, which is your major bone feature of the sphenoid bone. Questions there? We've got these greater wings and lesser wings, but really it's just recognize the wings and you'll be able to know what that is. Now, sella turcica, yep, the location of the pituitary gland. Now, as far as a sinus that can be taken with the sphenoid bone, we do have the sphenoid sinus, and that's this blue guy all the way toward deepest part of your face, right in there. Sphenoid sinus. One of the most common confusions of answers that I've seen on these practicals over the several campuses I've taught this at is the confusion between the sphenoid bone and the ethmoid bone. I think it's just because your mouth has to do the same basic stuff to get the sounds out, but keep them straight. The ethmoid bone is this brown bone right there, and it's basically a rod of bone that runs right down the middle of your skull versus this wing type thing of the sphenoid bone. We do have two different bone markings of importance on this very central, tinier ethmoid bone. It's this yellow one right here. And what you can see, if you take a good look at these skulls with that ethmoid bone, there's a ridge that runs right up the middle of that sucker. That ridge is called the crista galli. And what the crista galli does is it grabs onto the membrane that's holding onto your brain, and it anchors your brain in place. In fact, this is one of the very few places your brain is actually held in place, which is why concussions are a thing. Right? It's just these membranes that are holding your brain inside of an ocean of liquid, but when you stop, well, inertia is a thing. Your brain keeps going forward, and because those membranes tie in here to the crista galli are flexible, your brain has the space to kind of come in and punch the front of your skull, equals concussion. Yeah? Crista galli. The other thing we've got here, in the brain just north of this, I should say just superior to this, are the olfactory bulbs. that you smell with. And so those olfactory bulbs are sending down bare nerve endings through the cribriform plate. That's all these dots that you can see on either side of that crista galli right down the middle. That's for your smell neurons. In fact, this is one of the very few places in your body where bare neurons are just out in the environment. We coat them with the mucus of the inside of your nasal passages, and their job is to hold on to all the 45,000 different smells that we can smell and send that smell information up through this cribriform plate to the olfactory bulbs, which contain your smell maps. Questions on sphenoid versus ethmoid bone? All right. Then in the ethmoid bone, really where you're going to be able to see it is this yellow here. Not the pink in front, that's a different one. We'll talk about that in a second. It's the yellow as you take this person's eyeball out and look at it from the side. Kind of dark. Well, you could also cut their head in half and look at it from the top. All right, as far as the ethmoid sinus goes, that guy is in green here. Then we get into the mandible. Mandible is functionally your jawbone, right? And with that, we've got the body of your mandible, this mandibular ramus, which is just a flat projection, and a mandibular condyle, which kind of sits up right here in the temporal bone, just in front of your acoustic meatus there. For those of you who have ever suffered from TMJ, this is the issue right there. That articulation does not do very well, so your jaw gets locked shut or it gets locked open. It's a real fun thing to eat a cheeseburger with this if you've ever had it. And this is a thing that a lot of times will fix itself with age as your skull gets more proportional. But that condyle is the point of articulation for your jawbone or mandible with the rest of your skull. Right? Then we've got the coronoid process up front, which kind of sets this up to fit inside your zygomatic arch and kind of keep things lined up appropriately as you go up and down with your chewing and talking. Questions here on the mandible? All right. That goes hand in hand with your upper jaw. That's the maxilla. Purple on the screen, orange here on my model there. And that's just your upper jaw. With the mandible comes the hard palate, or the palatine process. Right? And if you run your tongue up the top of your mouth, you can feel hard in front and soft in back. Well, that's that hard stuff is actually your mandible you're feeling right in front. And in the back, it kind of opens up a little bit to give you the soft palate, which you can see as a consequence here and here, those holes. Their maxillary sinus, this last one, that's shown in pink here. Then we start getting into the detail bones of your skull. I hope nobody gets this one wrong, but nasal bone is here. Not down in the floppy part. If you're going to break your nose, it's got to be up in here, right? And so nasal bone. The zygomatic bone is your cheekbone. It's this. It sets up the outer lower third of your orbit here. It meets up with your zygomatic bone, and collectively we've got your zygomatic arch here. If you've got high cheekbones, you've got high zygomatic bones is really what you've got here. And that articulates with your maxilla in front, your temporal bone in the back as well. Now when you cry, which nobody's going to do after this test, I'm sure. But there's a point to this story. When you cry, what you've got is a lacrimal gland. And the gland itself for your tears is up here in the upper outer corner of your eye. And how this system works is this sends the tears down over your eyeball. It washes across your eyeball to the lower middle corner. And then you've got that pipe down here. That's called the lacrimal duct. And I'm sure you've cleaned Mr. Sandman out of your eyes in the morning. And the reason why it's always in this corner is because that's the direction of tear flow. And throughout the night, all the garbage your eye collected gets washed into the drain. And it doesn't go down the drain, it just collects on top. You clean it out in the morning and you're good to go. When you cry, you probably have noticed that you have to blow your nose a lot. Because there's a duct right there and it just goes direct down into your nasal cavity. So after you're done crying, it's not that you actually made more snot. What you're blowing out of your nose is the tears that didn't spill over the side but went down the lacrimal duct. This bone, the lacrimal bone, is named after that lacrimal duct. And so it's basically exactly where we would clean Mr. Sandman out. In this case, it's the pink bone just inside the orbit. Does that make sense? Any questions so far? All right. Now we start to get into some of the real detailed parts. In the back is the easiest place to see this guy. You can see the inferior nasal conchae or turbinates here through the actual nasal opening, but it's easier to see back here. It's the green. And what's going on here, if you were to give yourself a cross section, all of your nasal conchae, which is basically the nasal snail, the turbinates like a fan, what's happening is you're breathing in and the air circulation is set up. Let's see if I've got a better picture. I do not. The air circulation is set up to actually spin. And so when you're breathing in through the nose and out through the mouth, that breathe in through the nose is doing a couple things for you. It's spinning the air before it allows it down in the lungs. And all this is surrounded by mucous membrane, sticky stuff. So when we spin it, what happens is all of the spores, the bacteria, the dust, the garbage, a good proportion of it gets spun out into that sticky stuff. It sticks. You know, boogers are sticky for a reason. This is the reason. And now your air that you're breathing down into your lungs is cleaning. It's also going to pick up some of the moisture from those membranes as it spins around and give your lungs a break as far as the drying action of the air. That's why they're called turbinates, because it's spinning the air, kind of like a turbine, or conchae for the spiral shell of a conch. Make sense? All right, so that one. Also in here, we've got the nasal septum, which is part membrane, part bone. The vomer bone straight up the middle of your nose. In this case, this is gray sucker right there, sets up the left-right separation between your two nasal passages to get up into those nasal turbinates. Questions there? All right. Now we get these sutures of your skull. We've already talked about the lambdoid suture, right? We've also got a suture that if we were to cut right down it, we would get a mid-sagittal section, yes? And so we call this between your parietal bones, that's your sagittal suture. We've also got the between your parietal bones, I should show it here, and your frontal bone. That's called your coronal suture, because if we cut this way, it would give you a coronal section, yes? And then down between your parietal and temporal bones, we give you the flat suture or the squamous suture, which is that. Not sure why it's called the flat suture, probably because it's as close to flat as we've got. And so those are the different joints between these very much immovable bones. Questions on the skull? Beauty. So we're moving this along. We have in your axial skeleton one bone that is not attached to anybody else, and there it is right there. I can't take the skull off and I can't pull the thing up, but if you look down in here, we've got this bone. That's called the hyoid bone. It's the only bone in your body that doesn't articulate with any other bones. And the whole point of that hyoid bone right here is to help you speak. Your tongue, your muscles, they all use that hyoid bone as an intermediate in order to turn some corners in your neck that would otherwise be too complex for us to get this job done. So a muscle pulls on the bone, which then pulls on something that then pulls on the next thing, and that's how we actually get swallowing and speech happening. And that's what the hyoid bone is for, right? The only bone that's only attached by anything by soft tissue. Then we get into the spine. And your spine has several sections, yes? And it just has to do with what they're innervating. So your cervical spine is your first 7 vertebrae. So it goes C1 to C7. And if you count them up, you've got 1, 2, 3, 4, 5, 6, 7. And you can run this down the back of your neck, and you can feel that very first prominent vertebrae as you're moving down. That prominent vertebrae that you feel is called the vertebra prominens. And it marks the official anatomical end to your neck. That's C7. Once we get further than that, we've got 12 thoracic vertebrae that interlock with each other pretty significantly. In the thoracic vertebrae, if you look at them from the side, they look like giraffes. A giraffe's head. And that long giraffe's head, what that's going to do is going to interlock with the transverse processes of the vertebrae below it. And if you try to actually do any flexibility of this part of your body, you're going to find it doesn't happen. And the reason it doesn't happen is because that giraffe's face of your next 12 vertebrae, the thoracic vertebrae, interlock with these sideways transverse processes, and it restricts the motion. Why? You've got a breathing apparatus in here that must always be open. It works by vacuum. If we twist you there, you stop breathing and die. You've also got a heart in there that needs the space to work. And so we restrict your motion in your thoracic region simply to allow the wide open thoracic cage to stay that way. Does this make sense? All right, now from there, we've got your lumbar vertebrae. Your lumbar vertebrae are very big in the body because they have to hold up all the weight of everything north of that, right? Lumbar vertebrae is basically the workhorse of your back. And this is the reason why if you get into your late 40s and 50s without back problems, congratulations, you're in the minority and you're winning life right now. Because these guys take all of the weight that's above them. And if you're busy doing things like lifting with your back, well, this is the area of most concern, right? And so your lumbar vertebrae, there's only 5 of them. They are very large in the body because they've got to basically support your weight without compressing. But we also get a lot more flexibility here. This is where flexibility is. And if you look at the profile of a lumbar vertebrae, they look like the face of a moose. And that moose's face, a little bit blunter, quite less protrusive, that doesn't lock in with the transverse vertebrae as well. I'm sorry, the transverse processes of the lower vertebrae as well, which means we get quite a bit more flexibility from the lumbar region. So if you've ever done the kettlebell thing, that's where we're working. Questions here? Now, the biggest workhorse of your spine has actually been forced to work so hard, it stopped being individual vertebrae, and it just took the lower 5 vertebrae you had and fused them all together into the sacrum, which is actually several vertebrae all fused together. Why would we fuse them? So we could fuse them in with your hips. This is a bipedal adaptation, right? 2-legged adaptation, and support all of the weight from the hips up. And we needed that extra fusion and size there as we moved to bipedalism, and we were counting on our back to hold all this stuff up, right? And then at the very last, we've got a tail. Many people are born with tails. Unless you're mom or dad, you likely won't know it, because the first thing the doctor's going to say is, you want your kid to have a tail? Mom and dad typically say no, and they say, okay, we'll be right back. They go chop it off, and it's done. Right? We all have tails. Sometimes people get born with the tail sticking out. Most of the time not, right? And so that's your last 4 fused vertebrae. We lost our tail as we lost the need to balance ourselves. As we got kicked out of the forest and forced into the grasslands, that tail became less of a balance and keep us in the trees in survival, and became more of a handle for predators to grab us with. And so we just lost it. So this is one of these vestigial organs that we still retain because it's not killing anybody. But if you've ever broken your tailbone, you understand how much that hurts and how you wish somebody might have killed you then, right? So that's your spine. Questions here?
So what's the name of the tailbone?
Tailbone is the coccyx. All right, so with the individual vertebrae, with your cervical vertebrae in the neck, they have, yeah, go ahead. I am, just now, yep. All right, so with your cervical vertebrae in general, listen guys, what you need to do to separate these is just understand the basics of some things that need to happen in each part of the back. The first one is that you've got vertebral arteries that start here and need to feed your brain. This is the only place on your back where you need vertebral artery space, because it starts at your shoulders and it feeds your brain. It doesn't go down, it goes up. And so only your cervical vertebrae will have these holes on either side. The transverse foramen, and that's for these vertebral arteries. Further south of your neck, those holes don't exist. So if you don't see those holes, it's not cervical. If you see those holes, that's a neck vertebrae. And then it's just a matter of, is it one of the special ones? So that's the easiest way. The other thing you're going to notice here, you got plenty of flexibility in your neck, and that's because these transverse processes, there's nothing locking into place with next vertebrae, like in your thoracic or lumbar section. Your atlas is the first because Atlas holds up the world, right? Greek mythology. Your axis is what you turn around on. That's your C2. to answer your question, yeah? And so with that atlas, what you've got are very, very non-pronounced vertebral foramen, transverse foramen, although they're there. You've got almost no spinous process there. And a very nice, smooth part of these condyles here. And what this is going to do is your occipital bone is going to sit right on top of atlas. This matches with the occipital condyles we saw around the foramen magnum, and you do this. The axis is the C2 vertebrae. And the really important thing about, what the heck just happened? The really important thing about the axis is this process right there. It's called the toothy process, or the odontoid process, because it looks like a little tooth sticking up. What's going to happen is you've got muscles that are going to grab here and then come out to the side of your shoulder. And so when I contract this side of my shoulder, what happens is this muscle pulls on that odontoid process, and then my whole head goes this way. And if I squeeze this side, it's going to pull on that odontoid process, and my head goes that way. And so the entire no motion you've got is completely dependent on that one extra process that's coming up there. And that's your axis. So because you're spinning around your axis. All of the other cervical vertebrae, they're all different, but really you're just looking for that transverse foramen for your vertebral artery, and you know it's a cervical vertebrae. Then you've got your thoracic vertebrae. Hey, check out the giraffe. Do you see it? That's it. And that's why you've got no flexibility here. They lock into these transverse processes on either side and restrict your ability to move. That's on purpose, right? And then from there, notice no transverse foramen here. And functionally with your thoracic vertebrae, the one thing you're going to articulate with are other vertebrae and your rib cage. Now with your lumbar vertebrae, you see the moose? Can you see that face? I don't know how many people spend time north, but trust me, that's what a moose face profile looks like. And what you're getting is less interlocking with the other vertebrae around, which is going to give you the extra flexibility you have of your lumbar region, yes? Make sense? Also, no transverse process, no vertebral arteries here. On a really big, thick body to support all that compression weight of everything it's carrying above it.